start your speech. You can go live now.
Good evening, everyone. Hetero Healthcare welcomes all delegates to this informative and experience-filled webinar. Today, we are here to shed light on first-time recently launched molecule in India, Polmacixib, which holds great promise in the field of pain management. We are excited to delve into its potential benefits and implications for patient care. So without any further delay, I would like to hand over the session to our medical advisor, Dr. Prashant Khandeparkar, to introduce our moderator and panelists for today's evening. Over to you, Doctor.
Thank you very much. Welcome, doctors, once again. It's our pleasure to have this panel discussion on Unveiling Polmacixib, current experience and future opportunities. The moderator for today's session is Dr. Ram Prabhu. Dr. Ram Prabhu, as we know, is MS Ortho from KM Hospital, FRCS and FICS. His spine trauma advanced training is in France and Germany. Fellowship in France, Germany, Hong Kong, US in trauma, spine and arthroscopy. Sir has delivered several lectures, orations and attended several symposia, both national and international. He has held more than 200 workshops and has taught more than 5,000 orthopedicians both in India and abroad. Sir has been organized several national and international conferences and has been chairperson and president of various orthopedic associations, notably president of Indian Orthopedic Society 2017. Sir is a reviewer of JBJS and has co-authored 4 books in trauma management. HOD in VN Hospital. Currently, sir is HOD in Wadia Hospital, medical director at Mulund Hospital and Mukund Hospital, and consultant at Hiranandani. Welcome, Dr. Ram Prabhu.
Thank you, Dr. Khandeparkar.
The other panelists are Dr. Kaushik. Dr. Kaushik is from Barasat, West Bengal. Sir is MS Ortho, joint panelist surgeon, joint replacement surgeon, arthroscopic surgeon, sports injury. Sir is executive member IMA, Barasat Orthopedic Doctor Welfare Association. The next panelist is Dr. Avinash Singh Chauhan. Dr. Avinash Singh Chauhan is MCH Ortho, consultant ortho surgeon, spine trauma, sports injury and reconstructive arthroscopy and joint replacement surgeon, Jalandhar, Punjab. Sir is member of Indian Arthroscopic Society, Indian Arthroplasty Society, National Association of Interlocking Surgeons and Trauma Society of India, Jalandhar. We also have welcome Dr. Chauhan. We also have Dr. Bhaskar with us. Dr. Bhaskar is a joint replacement surgeon, spine and trauma orthopedic surgeon in Nellore, AP. Once again, welcome to the moderator and all the panel doctors. Welcome to you, Dr. Ram Prabhu. Hand over the session to you. It's all yours.
Dear friends, thank you very much, Dr. Khandeparkar, for your generous introduction of myself and the panelists. And it gives me a great pleasure to be with all these participants, panelists, and esteemed surgeons across India, that we are going to talk about some exciting molecule which has come for our use and for the patient's use since February 2023, where the DGC has approved this molecule for general use, especially for osteoarthritis. This molecule was known before in 2015 in South Korea, and it has been used since then. And it is because of this popularity and also the effective nature of this molecule and also the safety profile that it is soon going to be a great molecule to be used, especially in osteoarthritis. The indications are going to be increased when we have the confidence in this molecule over a period of time. So can I have the slides, please? Can I share the slides? Yeah, so I'm going to give you a brief introduction of this molecule and its effective nature in managing the osteoarthritis. All of us know that osteoarthritis is there in India, and probably more than 60 million cases are having mild to moderate nature of osteoarthritis in India. And that gives a great opportunity for all orthopedic surgeons to use this molecule across all this osteoarthritis, especially in the lower limb, which are weight-bearing joints, and also the back, the spine, and other joints like shoulder, etc. And we see these cases all throughout our practice, day-to-day practice, and we see that it is enormously helpful in managing osteoarthritis joints, especially in grade 1 and grade 2 cases. Next, please. Next. So when we see that the worldwide prevalence is extremely wide, and we know that there are some risk factors which are modifiable and not modifiable. The modifiable ones are the easy one to manage, which is obesity, lifestyle problems, occupational conditions, comorbidities, and the diet. And all these different ways of managing these problems are there, and all of us know about that. But unfortunately, there are non-modifiable risk factors also, like age of the patient, the gender, genetics, and race. And all these risk factors have to be taken into consideration when we are managing the osteoarthritis. Next, please. So we have a pathophysiology of osteoarthritis, where I have talked about the risk factors, basically the mechanical stress and the abnormal joint mechanics is the cause of osteoarthritis. We know that even increase in 5 kg of a person's weight can increase the load up to 40% on the knee joint and the weight-bearing joints. So this is what we have to remember when we are managing this osteoarthritis in day-to-day problem. Next, please. So there are some limitations and challenges in treatment, and all of us are aware of those, taking into consideration the modifiable and non-modifiable problems. So we have many traditional NSAIDs and COX-2 inhibitors which are there, but then there are problems and limitations of managing them. So they provide us pain relief, and joint damage also is reduced. So both these aspects which have to be treated become sometimes difficult. And then there are, in the extreme cases, we have surgical options which are there, and some interventions like arthroscopy, joint replacement are also possible. But all these factors are when this joint becomes beyond the medical treatment. Next, please. So let's talk about this wonderful molecule which has come into the rescue of patients having severe osteoarthritis and mild to moderate osteoarthritis. So Polmacixib is a very specific novel NSAID, and we know that it is purposefully developed non-steroidal anti-inflammatory drug, which is PDA-NSAID, that is what we call it, to specifically inhibit the COX-2, and it is useful for the treatment of pain in arthritis patients. Next, please. Next. So the mechanism of action of Polmacixib, so it has a unique dual mode of action, that it inhibits both COX-2 and carbonic anhydrase. And this is a very important action which helps us not only reducing the pain in the patient, but also having a great safety profile. Next, please. Next. So this mechanism of action of Polmacixib is extremely important, and that so in the tissue, it is highly enriched with carbonic anhydrase. It maintains a low systemic exposure to Polmacixib. So when the drug goes into GI tract, blood, or kidney, it binds to the carbonic anhydrase and in red blood cells of whole blood with low concentration in plasma, which leads to Polmacixib showing reduced COX-2 binding due to competition by CAs, and it reduces the adverse effects associated with COX-2 inhibition in these organs. So RBCs transport large amount of Polmacixib in protected and in active state to tissues with a low CA activity. So which leads to the tissues with low CA activities, the inflamed joint, the Polmacixib dissociates from carbonic anhydrase, and it increases concentration of polmacixib in inflamed tissue. So this is in short the mechanism of action of polmacixib. Next. Next, please. So these properties of polmacixib are very important, and this has been researched widely, and it was found that polmacixib concentration in whole blood was 50 to 70 times greater than that of plasma. The median Tmax values in plasma was 3.5 to 7.3 hours, while that in the whole blood was between 3 to 10 hours. Plasma polmacixib showed dose proportionally, and the main tended to show slightly longer half-life than the women. Next. Next. Next, please. So when we did the phase 3 study, the safety results were shown as the reported treatment emergent adverse reactions were mostly mild and consistent with expected side effects of COX-2 inhibitor drugs. So this is one important aspect of polmacixib, that it is extremely safe, and it demonstrated a similar safety profile to celecoxib and other COX-2 inhibitor, which have reduced incidence of GI disorder compared to other NSAIDs. And this is important that this has been checked with the comparative study with celecoxib and also some placebos, and it has been shown that it is extremely safe and very efficacious. Next, please. Next. Next, please.
So this is next slide only.
So extension study results, the drug remained well tolerated with a comparable safety profile to the initial 6-week treatment period and other COX-2 inhibitors. There were no notable increase in the incidence of any adverse drug reactions, and there are not any clinically relevant finding in the analysis of clinical laboratory tests, vital signs, ECGs, or physical examination. And this is again very important to find out whether there are any, whether it is cardiotoxic, hepatotoxic, or renal toxic. And this drug has been proved that it is none of this, and which is again makes it more safe. Next, please. So the conclusion of phase 3 study was polmacixib 2 milligrams only. So that is again the dose is very low, demonstrated superior efficacy to placebo and non-inferior efficacy and safety to celecoxib in treating osteoarthritis over 6 weeks period. The 18-drug-week trial extension showed consistent results, suggesting that polmacixib is safe for long-term use. Next, please. So in the pharmacokinetics, it is important to find out about the absorption, which is very good in this, which the studies have shown. And also the distribution of this drug is very well. And this has been studied in 2 milligram as well as 8 milligram. And this was given over a period of 6 to 8 weeks. And they have found that within 10 days to 15 days, you start getting the desired results. Next, please. Next. So the metabolism is also extremely good, which has been shown in this. The excretion also through the renal tubules is good. So which also helps us to find out whether there are any side effects. Next. Next. Next, please. Next, please. Yeah. So in summary, polmacixib 2 milligram capsule, it is NSAID, it is selective COX-2 inhibitor. It gives symptomatic relief in osteoarthritis, especially because this has been approved. 2 milligram once a day to be administered after meals. Daily dose should not exceed more than 2 milligrams. And also there are some drug interactions which we have to be a little careful about when the patient is on other drugs. It is also there are certain contraindications in patients with allergic reaction to sulfonamides, history of asthma, acute rhinitis, nasal polyps, angioedema, urticaria, uncontrolled hypertension, edema of or fluid retention, hepatic and renal impairment, active peptic ulcer or gastrointestinal bleeding, IBD, congestive heart failure, established ischemic heart disease, peripheral artery disease, pregnant and nursing women, hyperkalemia, blood coagulation disorders, and taking anticoagulants. So this is important that when you have to remember that patient who has comorbid problems like this, we have to sort of refrain this drug from using. Next. So to summarize, Polmacixib, a COX-2 inhibitor that has been developed recently for the treatment of pain. It is a dual inhibitor of COX-2 and carbonic anhydrase. This dual action of Polmacixib is believed to minimize the adverse cardiovascular effects of COX-2. It is well tolerated and clinically efficacious in treating pain associated with OA. Polmacixib is safe for long-term use. So, next.
So the presentation is now over.
Okay.
Now further we will be
in short, when we realize this and when I have used it in almost more than 100 patients, I have realized that it is extremely safe. At the same time, it is very effective. And that is what we need to discuss this amongst our panelists. So I will just share one case out of all these 80 to 100 cases that I have treated this in last more than 3 months. We gave this Polmacixib molecule to a 46 years old patient with a consistent knee pain. And on X-rays and other investigations, we found that she had grade 2 osteoarthritis and also pain in the hip and other joints. So even after 2 weeks of use, the patient showed improvement in doing daily activities. We realized that not only did her pain reduce, but also her mobility was improved, and she was extremely happy that she started using this. And in fact, she was on different NSAIDs for the past 6 to 8 months, and she had not got much relief on other NSAIDs. And she was so happy that she started taking this Polmacixib. So this not only reduces the pain, but also improvement in the range of motion. I've also used this in more than 100 patients, as I told you, with different indications, because as I became a little more confident of having very good results after using this, I used that in rheumatoid arthritis, some backaches, spondylosis, and also some managing pains in shoulder problems also. I've used that in frozen shoulders, and the patient had got relief after that. So I would hand over the mic to Dr. Khande Parkar for getting other panelists involved. Thank you very much.
Thank you, sir.
Next. Dr. Bhaskar, can you just talk about your experience? Dr. Bhaskar, please. Dr. Bhaskar, unmute yourself and please talk about your cases. If Dr. Bhaskar is not there, he may be busy with his surgery. I can request the other panelists to get in, please. Next, please. Dr. Chavan. Yeah, Dr. Chavan, please talk about your experience using this molecule.
Good evening, everybody, and welcome all the doctors. Our main concern in osteoarthritis is pain, stiffness, and functional mobility. So, when we treat this, what we have to keep in concern that osteoarthritis is a chronic disease and it cannot be reversed. It can be only improvised, and that is how Polmacixib becomes such an important molecule for us. As Dr. Ram Prabhu has already discussed, it is COX-2 inhibitor with CA inhibitor. So there is a competition between CA and COX-2 inhibitor. So COX-2 inhibitors get attached to RBCs, they don't get into plasma, and when it is required in the inflamed joint, that is their availability is possible. This is what happened with my patient. Patient came to me, 66 years old, male patient, and patient had bilateral osteoarthritis, grade 2. Patient also had varicose veins in the right leg, and the pain was more severe in right leg as well. Then the patient went for varicose vein surgery. Patient got surgery done, relieved, came back to me after a month. Then I started him on Polmacixib. And after getting the treatment with Polmacixib, patient had improvement in pain. That is one good thing. But the patient also reported to me that his functional mobility has also improved. Stiffness and swelling has gone down. And during the therapy, I didn't prescribe any PPIs to the patient because the safety profile of Polmacixib is as such that GI, cardiovascular tissues which have more of CAs,
Good
kidneys,
night.
liver, all these tissues which are having lots of CA inhibitors, so they never get affected. So even after that, there was no problem of hypertension or any ECG changes, no nothing. And patient was so happy with this that he has brought one of his more known relative who was hardly 46 years old, active male, and serving in armed forces with a back pain. And I could find out there is a spasm, there is a spondylolytic changes, and I prescribed the same thing to him. And the patient reported that I'm very happy because in Punjab, our lifestyle and eating habits are different. So the older patient was like fatty, but the armed forces person was fit. Even the patients are responding in such a good way about their molecule. And I think as Dr. Ramprabhu suggested, we can use for frozen shoulder and other indications as well.
Yeah, so Dr. Chavan, thank you very much for your experiences. As we know that we do not have a long-term experience of this drug because it is just last 3 months that I have been using this with Will. Also, when it was launched, before that, I also used it from other sources. And there are a couple of very interesting questions. One is from Dr. Chaudhary. He said, how much period we can ask patient to take this molecule? And I have used this for about 6 weeks in most of the patients, but it is possible that some people can give it up to 3 months, but we really do not have any experience of using it for longer time. And then Dr. Raja has asked that, is it as effective as Itracoxib in reducing pain? And that is very interesting. We have been doing a comparative study with Itracoxib because which has not been done. And I am sure over a period of time, this is going to replace Itracoxib because of its safety profile and also the effective pain reduction. There is also one question from Dr. Alek Rathod that he asked that what is the difference between Itracoxib and Polmacixib. But we have been doing this, and I have found that we are going to do the different comparative study between Itracoxib and Polmacixib over 6 weeks, and soon we'll be coming out with this differentiation and how effective Polmacixib is. So can I hand over the mic to Dr. Khande Parkar to take it further?
Yeah, Dr. Kaushik, you have your studies?
Yes, sir. Good
Yeah,
evening,
yeah.
sir.
Yeah,
Yes,
Varsha,
sir.
can you take the slide for? Yeah. Can you
Yes, sir.
present us? Yeah.
Sir, I have used this Polmacixib around till today, like 25 to 30 patients.
Okay.
And there is a case study over here. So a 62 years old gentleman he has comorbidity with diabetes and hypertension, and he came to me with both knee joints pain with swelling and had some stiffness. And some insights was given from outside from some other doctor, but he was not feeling good, and he was not satisfied. So that's why he came to me, and he heard my name from somewhere. And whenever I have seen him, and I applied this medicine, this Polmacixib 2 milligram once in a day, and I asked him, you don't need any other like proton pump inhibitor or antacid. It is very much safe for you, and this medicine, I think it will work nice. And after taking this medicine, he came to me by like after 5 to 6 days, and he said, "Yeah, I am feeling better." And the pain subsided, like the 60 to 70% subsided within this time, and the patient was very happy. And so I think so. This is the very safest one till now among all other these COX inhibitors. So I am writing this medicine, this Polmacixib.
So can I ask Dr. Kaushik
Yes,
and Dr. Avinash both, in which patients have you used this Polmacixib the most? Can you both?
Sir, yes, sir. Mainly joint pain. In case of joint pain, and even after that, I have used this medicine in some other aspects also, like low back pain. Some patient came to me like for last 2 weeks. She is coming to me. I have applied some other COX inhibitors NSAIDs, but it was not responding. But whenever I applied this thing 2-3 days back, and the patient party came to me today, she is doing well. Sir. So this very like good.
Yeah. So how fast did you see that the patients had relief? Can you just arbitrarily tell me in how many days the patient started having relief?
Sir, you see, this last patient I have seen 3 days back, and this medicine, the patient has taken only 3 doses, and other NSAIDs was not working that much. Not working on that was not working. I don't know why, but in this medicine, whenever I applied this one, and this patient party came today with some MRI, and he said the patient is doing better than the before. So within 3 days, I got results. Sir. He said like 50% pain gone within 3 days.
Dr. Chavan, what is your opinion on this?
In my experience, osteoarthritis of knee in 1 or 2 days, patient starts feeling relief, but comfortable level of patient's activity comes after 5 to a week time. And even in back pain patient, because they come to us after a chronic pain, history of 3 months or 6 months, so that also takes minimum 6 days to 10 days. Even to my surprise, I tried this molecule in grade 1 AVN of hip, and that patient gave me the positive response after 10 days. Initially, he was hesitant. He फर्क नहीं पड़ रहा. Then I said, you continue with the medicine, you will feel better. Patient persisted with that, and he had the medicine. But after 10 days, patient said, sir, I am ready. Even if you want to do a surgery on me, I said, that will plan later on, because it's a rainy season. I don't do elective surgeries in rainy season. We can do it in winters. So patient is continuing with the medicine and he's happy with that also. Very good.
Yeah, so there is some questions. Dr. Giri has said whether it can be used in CKD patients, and Dr. Rane has asked whether Polmacixib can be used in asthmatic patients. As I told you in the slides and before, that we should be very careful in using this if there is a comorbid problems like CKD and asthma. And other question was asked that whether we have to taper the dose. Now that is not necessary, that we can continue to give 2 milligrams to everybody, and there is no need to taper, and that is what not recommended, nor have we used it in a tapering dose. So which time of the day do we use this, Dr. Chavan and Kaushik?
Sir, I
In daytime
prefer,
after food, sir.
After food in the morning,
Yeah.
breakfast.
Yes, sir. Yeah, after like yes, after breakfast, like 10 o'clock or like 9 o'clock in the morning after
So then
taking
Dr. Chavan,
food.
sir, my preference is in osteoarthritis cases or AVM, I go for morning dose. But in back pain patient, chronic back pain, because after the day's activity they develop the pain. So I go for mid-afternoon, right about 5 o'clock or 6 o'clock, so that patient is relaxed and has a good sleep with pain relief.
so one other question that I can ask you, Dr. Vinash, that whether using piroxicam or diclofenac, have you found this to be more effective and the pain relief is much faster and more effective for a longer period of time? Do you think so?
Sir, my experience in this case is for some patient pyroxicam suits. Other patients always complains of gastric disturbances. So Polmacixib have been replacing slowly in the patients of naproxen, indomethacin, and even piroxicam.
So
Diclofenac, acetaminophen.
are you giving any antacids or PPIs along with this polmacoxib as a precaution, or you don't?
I don't, unless until patient is like sometimes no patient has said, I have a problem with acidity, I have an issue with it. Then I prescribe once in a day, and that also simple Aciloc. I
Okay.
use
And
Aciloc, plain
have you
Aciloc.
had any occasion to concomitantly give paracetamol along with this, or standalone you found it effective?
No, I have not used paracetamol till today.
What
Even
about
in
you, Dr. Kaushik?
No, sir, I didn't use paracetamol. Only Polmacixib. Yeah.
And did you give any PPIs along with it?
No, sir, no. I didn't prescribe to any patient
So
with API.
you didn't think that there was a need for it?
Yes, sir. And there is no complication. There is no side effects. There is no gastritis. Every patient was doing well.
Yeah,
Even
so
in,
that is what even I have found, that none of the patients that we gave complained of any gastritis or discomfort. Okay, and I didn't require any additional PPIs along with it, nor have I also combined this with paracetamol or any other painkillers, so-called painkillers or NSAIDs. So I found it the same way as Dr. Kaushik and Dr. Chavan.
so even in acute cases, paracetamol was not prescribed. I mean, polmacoxib took care by itself.
Yes, it did. It did. That's all. Any more questions that Dr. Khandeparkar you have?
Yeah, one thing which stress me is amongst of the symptoms of osteoarthritis like stiffness, restriction of movement, limitation of range, which are the symptoms which respond very fast and which are the symptoms that are little resistant to respond?
I found pain relief was the first one which was seen. The mobility was little more than about say 10 days to 15 days that they said that they are little more mobile, the range of motion improved, and their walking, etc. also improved later on. So the first was pain relief, later on the mobility. What is your experience, Dr. Chavan and Kaushik?
So my experience is that pain relief is the first thing
Correct.
that gives the patient confidence enough to improve the mobility. And once they start moving around, stiffness goes slowly out of the range and the patient becomes more comfortable because stiffness will persist unless until functional mobility is improved. So that is my experience. Pain relief gives patient confidence for functional mobility, exercises, what we suggest them, and then stiffness goes off slowly and slowly.
So there is one interesting question from Dr. Ramesh Jain. How does diclofenac and polmacoxib differ between each other? Now, this is an interesting question because there has not been any comparative study which will statistically prove one drug's efficacy over the other. But I'm sure we will be doing that over a period of time and we'll be able to come out with some kind of robust data about it. At the moment, we are in the process of comparing it with etorecoxib, and I'm sure soon we'll be able to give you some kind of statistical efficacy of this drug. Dr. Kandeparkar, any more questions?
Yeah, I think I'm getting one. Sir, I've got few questions. I'll just forward it to you. I think most of them you have answered, but I'll just forward them to you.
You can talk, you can ask also questions.
Yeah. I think you have asked most of them.
Yeah, most of the questions
Yeah,
which
yeah.
have been asked, I think we have answered.
Correct.
So there is one question
There is
from
just one.
Dr. Ranjot.
Yeah, sir.
Yeah.
Dr. Ranjot is asking, can we use rheumatoid arthritis along with DMRDs?
So, Dr. Ranchod, the thing is, it has not been approved as a indication to be used in rheumatoid, but we know that rheumatoid arthritis also can give rise to osteoarthritis as a secondary osteoarthritis. And I'm sure we can use this in pain relief and mobility improvement in rheumatoid. But as we get robust data, we have confidence, I'm sure we'll be able to use this as an off-label sort of indication in rheumatoid. But at the moment, it is not approved for it. But I'm sure over a period of time, we'll be able to use it for rheumatoid too.
There's one more question, sir, from Dr. Mahesh Bhosle. Is OD dose sufficient? And can we give steroids along with Polmacixib?
So OD dose is sufficient at the moment that we found out. I didn't have to increase the dose of any of these patients. Giving steroid is definitely your own choice. We can definitely give it along with steroid, but it is not recommended. If you think that Polmacixib standalone drug can help the patient, I don't think there is any need to give any steroids. And I myself do not give any steroids orally at least.
That's wonderful. I don't think there are any more questions.
Dr. Kaushik and Chavan, do you use it along with steroids or you still?
No, sir. No, sir. Only Polmacixib is used.
Dr. Chavan, did you require steroids in any of the patients?
Only one case of rheumatoid arthritis.
Rheumatoid, that is.
Yeah.
But currently it is recommended for osteoarthritis only.
Yeah, but in rheumatoid I have used it because of its pain relief capacity. And steroid, that also deflazacort 6 milligram, not more than that. And SARS, simple.
So there's one question which has come. How do you differ pain patches used in osteoarthritis and use of Polmacixib?
No, I didn't get the question.
How did you differ pain patches, I mean those NSAID patches used in osteoarthritis and use of Polmacixib?
You mean the combination of both or?
No. How, I mean, which is better and how would you place them?
I mean, I don't think I can really compare them with patches. The patches that we use are mainly as an analgesic.
Okay.
But this is much more or better way to manage the inflammation, the pain, and also the mobility. Okay. So the patches is going to be only helping you halfway. I am not against using patches. Of course, I use the patches, but I think the efficacy of this is much better than the patches.
Correct.
And I did not give any patient who were on Polmacixib, I gave patches to them. Okay. So it was not concomitant treatment along with the patches.
So plain Polmacixib helped in almost all of them. Yeah.
Almost all.
Yeah. I think that is all that's all the questions. Thank you so much, doctor.
Yeah, so thank you very much, panelists, Dr. Chavan and Kaushik.
If there's something more, we'll come back to
Bhaskar
you.
had some emergency, so he could not continue. Otherwise, we've had a very useful,
lovely session.
Productive, interactive sessions.
Importantly, we got good insights into the molecule and into the therapy and into the use.
Yeah, so thank you very much, Dr. Kandeparkar and the whole entire team of Hetero.
Thank you.
Got it possible today to interact with so many participants across India.
Thank you, Dr. Ram Prabhu. Thank you, Dr. Avinash Chavan. Thank you, Dr. Kaushik.
Yeah.
Thank you so much. Thank you for being here. And thank you all the doctors who have attended.
Good night. Enjoy the dinner.
So nice of you, sir. We had a great time.
Thank you very much.
That's been the learning part for us also.
Yeah, good. Thank you
We
very
learn
much.
everything
Kaushik.
from you.
Yeah,
Thank you.
Thanks, Sheetal. Thanks, Sandhya. Thanks,
thank you,
Varsha.
Jawan and Kaushik. Very
Thank
much.
you.
It was a wonderful meeting, both of you.
Yeah,
Thank you.
Thank you, sir.
thank you.
Good night, sir.
Thank you.
Good night. Good night, sir.
Good night, good
everyone.
night, good night.
Good night.